Assalamualaikum. Good morning, everyone. I'm Dr. Ibrahim. Will be your moderator for today. It is my pleasure to introduce our speaker, Dr. Abdul Muhaymin bin Mazeni. He is a medical lecturer in the Department of Biomedical Imaging, Faculty of Medicine, University of Malaya. He obtained his MBBS from Monash University, Australia, and completed his Master of Radiology at the University of Malaya. He has over 13 years of experience in radiology with a special interest in cardiac imaging, including coronary CT angiogram, cardiac MRI, and myocardial perfusion imaging. He has contributed to the research on coronary artery calcium scoring and pursue advanced training in cardiac CT, including cardiac CT level 2 training in Edinburgh. Today, he will be sharing his insights on beyond stenosis, the evolving role of CT coronary, highlighting how coronary CT has evolved from simply detecting luminal narrowing to providing comprehensive assessment of plaque characteristic, functional significance, and cardiovascular risk. Please join me in welcoming Dr. Abdul Muhaymin bin Mazeni.
Okay, thank you, Dr. Ibrahim. So today I'll be talking about the evolving role of the coronary CT angiography. So what is it? Basically, CT angiography is just an invasive, non-invasive tool to evaluate your coronary arteries, the four vessels, major vessels in your heart, which is the left main, the left anterior descending, the right coronary artery, and also the left circumflex arteries. So cardiac imaging started in 1979 when Godfrey Hounsfield actually wrote an article about imaging of the heart. So Hounsfield is popular. We use until now Hounsfield unit to measure the attenuation value of a CT scan. So at that time, he thinks that the complexity and cost may rule out such a machine being used worldwide. So this is what the machine in the 1970s looks like. So imaging of the heart is challenging because heart beats at 60 to 80 beats per minute and moves within the chest cavity. It's actually much easier to image things that doesn't move, like your brain or your abdomen, your kidney. Therefore, you need a high temporal resolution to image the heart. And the structure of the heart is both complex and measures in millimeters. Your coronary arteries measures only in millimeters and it's constantly moving. Therefore, you need a high spatial resolution to image the coronary arteries. So minimum requirements to perform a CT coronary artery is a 64-slice scanner and also ECG gating. So ECG gating basically stops the heart motion. As you can see on the image on your left, the RCA is not properly visualized due to non-ECG gating due to motion artifact. And image on the right with the ECG gating, you can outline the luminal area of the RCA adequately. So in our center, we use a state-of-the-art CT scan, which is the Canon Aculon 640-slice CT scanner. It can capture the entire heart in a single 0.24 seconds. Cost is for each examination is only 600 ringgit. Outside in a private center, it can cost up to 2,400 ringgit to 3,000 ringgit. So our price is actually Madani price. It's Harga Rahmah. It's quite cheap, 600 ringgit for a CT coronary arteries. However, appointment time is a bit long. So the next appointment is in April next year. So it has a high negative predictive value of 93 to 99% and high sensitivity and specificity of 90 to 94% and 95 to 97%, respectively. So this is the number of patients underwent CTA examination in UMMC. So we've been busy for the past 3 years. And from 2022 to 2023, we see a twofold increase in patients undergoing CT coronary arteries. So I don't know what's the reason to this. Maybe the traffic jam in PJ giving you a heart problems, perhaps. So for patient preparations, you need to check contraindications for nitrates and beta blockers, such as your heart blocks, because we're going to give nitrates and beta blockers for patients undergoing CT scan. They should take their medications, cardiac medications as per usual, and they need to fast 3 to 4 hours before the scan and abstain from coffee for 12 hours. For pre-medication, we give metoprolol to slow down the heart and to minimize motion artifacts. We give alprazolam to calm the patients a bit, and also the GTN to dilate the coronary arteries. So coronary arteries has a wide range of indications, but our main business is to rule out or to confirm coronary artery disease. And if you do have coronary artery disease, CT can actually grade the stenosis severity. CT also used for pre-intervention planning, so invasive coronary angiogram. You can do CTs or pre-CABG. CT can also be used to evaluate stent to look for in-stent stenosis. It can also detect congenital coronary anomalies, look for cardiac masses or thrombus, and also for valvular heart disease. Now I'm going to talk about CAT-RATS. So CAT-RATS is just the short form for coronary artery disease reporting and data system. So what it does is it improves communication and also to guide therapy. I will go through some examples of CAT-RATS so people can get a better understanding of what it means. So in CAT-RATS 2.0, there are 6 modifiers that was added, which includes the N, which is a non-diagnostic study, HRP high-risk plaques, ischemia, presence of stents, coronary artery bypass grafts, and exceptions. So usually the modifiers are added after the CAT-RATS score was given. So CAT-RATS actually look at the score is 0 to 5. 0 means no stenosis or normal study. 5 means total occlusion. It shows the amount of stenosis, whether it's minimal, mild, moderate, or severe, and it suggests further investigation. So especially in CAT-RATS 3, you need to consider functional assessment. And for A, you consider ICA or functional assessment. For B, you suggest ICA. But however, this all depends on the primary clinician, because I believe that every patient is different. So once you receive the report, it's for you to decide what's the best for the patient. So this is an image of a 60-year-old female with dyslipidemia and ischemic heart disease under GP follow-up, not on any medication. She presented with central chest pain for 2 weeks and was treated as a stable angina. CT was ordered for further assessment. And CT shows a squeaky clean coronary arteries. This is the LAD. We see that LAD is patent, it's normal in diameter, there's no stenosis anywhere, no plaques. And the LCX is also normal and the RCA is also normal. Therefore, we give a score of CAT-RATS 0 or no evidence of coronary artery disease. So for this patient, the management is just reassurance. Tell the patient that the patient it's most probably the chest pain is non-cardiac in nature. This is a 66-year-old lady with a non-specific chest pain. Exercise stress test is indeterminate. CT was ordered to rule out ischemic heart disease, and CT done showed minimal stenosis at the mid-LAD, which is a mixed calcified and non-calcified plaque. This is the curved MPR, and this is the straight MPR. So this patient was given a CAT-RATS 1. This is a patient with no known medical history, treated as unstable angina, presented with atypical chest pain, and CT shows mild non-obstructive coronary artery disease at the mid LCX here. We give a cut rats too. And this is a patient with a strong family history of ischemic heart disease. Echo shows normal EF with tribal mitral and tricuspid regurg. And CT shows proximal LAD, non-calcified plaque with moderate stenosis, 50 to 70%, and we give cut rates of 3. And this is a 63-year-old case of hypertension, dyslipidemia, and fast AF. CT done showed mixed lesion, calcified and non-calcified lesion with spotty calcification at the distal left main artery. Due to the high-risk features, we give CARES 4B with high-risk plaque features. And this patient, we immediately call the cardiologist for this. And patient actually did a coronary artery bypass graft 1 week later. This is a 69-year-old with unstable angina, and CT shows a total occlusion of the mid LAD. So you can see that the mid LAD is totally occluded with a hypoattenuated plaque, some calcified plaque, and another hypoattenuated plaque. So CT is also used to assess the patency of bypass graft. It shows good display of proximal and distal anastomosis. It can evaluate graft atherosclerosis, stenosis, or occlusion. We can also do a 3D rendering to help planning for revascularization surgery. So this is an example of patient who we did CT to assess the bypass graft. She's a 70-year-old lady with reduced effort tolerance, and CT shows patent Lima to LAD graft. We also get referrals for to assess in-stent stenosis. So this is a 57-year-old with ischemic heart disease done stenting in 2015, was recently admitted for hypertensive emergency and non-STEMI, and CT done shows hypointensity in the proximal segment of the stent. This is which totally occlude the whole lumen. So this is in keeping with in-stent restenosis of the mid RCA. So CT is also being used to assess diseases in pediatric patients, such as vasculitis, Kawasaki disease. So CT done showed LAD aneurysm and LACX aneurysm, and also the RCA aneurysm involving the proximal, mid, and distal segments. And this was confirmed with invasive coronary angiography showing the aneurysms at the segments. Sometimes we do get referral from for infective causes, such as the infective endocarditis. So in this CT, it shows aortic root abscess anterior to the aortic root. So in CARETs, CT is increasingly being used to detect high-risk plaques. So high-risk plaques are the plaques that are known to cause flow limitation. It's the one that causes ischemia, and it is the one which is prone to rupture, causing acute MI or heart attacks. So stable plaques are those that are calcified, characterized by large calcification, fibrotic tissue, and smaller lipid pools. Whereas high-risk plaques on histology, it contains spotty calcifications, large lipid pool on a critic core, which is covered by a thin fibrous cap. So these plaques can be identified by CTA. So these are the features of high-risk plaques in the mid LAD. As you can see, high-risk plaques has low attenuation. So plaques with attenuation less than 30 Hounsfield unit on CTA were found to be present significantly more often in patients with acute coronary syndrome. So another feature of high-risk plaques is the positive remodeling. It means that there's an outward growth of the plaque, but it doesn't really shows luminal stenosis. The positive remodeling is unable to be shown with invasive coronary angiogram. So another important feature of high-risk plaques is the napkin ring sign. So it is defined as a central low attenuation area adjacent to the coronary lumen and a higher ring-like structure surrounding this area. So on histology, it shows necrotic tissue with with the outer area of fibrous plaque tissue. So the napkin ring sign is strongly associated with the major adverse cardiovascular events. So the problem with calcium. So calcium may appear to cause severe amount of stenosis on CT. However, on invasive coronary angiogram, it doesn't really cause any flow limitation. So these are not really the bad guys. The bad guys are the non-calcified plaques. As you can see, it causes a significant amount of stenosis. And these are the ones who have a high risk of rupture, causing heart attacks. Now we go to the CT-FFR and also the CT perfusion. So CT-FFR is derivatives from CTA images. So it can be used to better define the hemodynamic significance of stenosis ranging from 50 to 90%, especially in CARETS 3 and CARETS 4A. So basically, it's just like a coronary pressure wire. So we measure the distal coronary pressure and also the proximal coronary pressure, and we get the FFR. So FFR of more than 0.8 is normal, less than 0.8 is abnormal. So this is an example of a normal CT FFR. This is abnormal CT FFR. On CT, you can see mixed non-calcified and calcified plaques at the proximal LAD. And on CT FFR, it shows reduced flow distally. So this patient is actually indicated for revascularization or invasive coronary angiogram stenting. This is a CT which shows a large amount of calcified plaques in the coronary arteries, and you would suspect that this one limits the flow significantly, but on CT-FFR it's normal. So we need to be careful when reporting or reading the reports with heavily calcified plaques, because most of the time it's not really flow limiting. Why do interventional cardiologists care about the FFR? It's to correctly identify and target lesions that will benefit from revascularization, and also to avoid stenting of non-flow limiting lesions. So achieving 1 and 2 produces better patient outcomes compared to planning revascularization based on assessment of stenosis severity alone. So CT perfusion, we image the patient both on stress and rest. So we actually need to give stressor agents for patients such as adenosine, dobutamine or regadenoson, and we see the amount of perfusion on the myocardium. So this is the left ventricular myocardium, and this is a normal myocardium, which takes up contrast, and this is abnormal myocardium, which doesn't take up contrast, and it appears hypoattenuated. So we want to look for fixed infarct if the area is present during rest, both rest and stress means it's infarcted. However, if it only appears on stress and it disappears on rest, then means patient have received reversible ischemia. And if there's no hypoattenuated areas, means it's a normal study. So basically, if a patient have reversible ischemia, you give Cartwright score with ischemia plus. However, if there's no ischemia, you give I negative. For peri-infarct ischemia, you give I borderline. Lastly, comes to photon counting CT, which is the newest generation of CT scanner. So unlike normal conventional CT scans, it's which measures the total energy deposited by X-rays. It measures the individual X-ray photon and measures its energy. So basically, it's just like a 4K TV. And our CT scan is just like a normal TV. So it has an ultra high spatial resolution. It has less image noise. It has reduced 20 to 40% dose reduction, and it has reduced blooming artifact. Therefore, it improves assessment of the stent lumen, improves assessment of heavily calcified coronary arteries and small vessels. So these are images obtained from photon counting CT. As you can see, the 3D image of the photon count CT is absolutely wonderful. And this is the CT multiplanar images showing stent with a patent stent, no areas of thrombus inside, and confirmed by coronary angiogram showing verifying the stent patency. This is another patient with stents within the circumflex coronary artery, showing hypoattenuated lesions within, causing severe occlusion, total occlusion, and coronary angiogram done showed corroborates the obstruction of the in-stent lumen, and the distal part of the LCX is perfused retrogradely through the collateral channels. So it has a high sensitivity and specificity as well. So in conclusion, role of cardiac CT are expanding. CT are able to guide clinical decisions and management. I hope you find my talk today helpful and informative. Thank you.
Okay, thank you, Dr. Muhaymin. That's a very comprehensive lecture on the CT coronary. Any question from the floor? If no question from the floor, I think we can conclude our lecture from Dr. Muhaymin. Thank you very much.